Welcome to The Explainer. Today we're diving into a really critical moment in the ICU. That moment when a patient looks like they're ready to breathe on their own, but something hidden, something secret, is holding them back. We're going to explore this hidden weakness that can cause some serious, even life-threatening setbacks. So let's set the scene. Picture this. We're in the ICU. There's a 65-year-old man. He's been battling severe pneumonia, and he's been on a mechanical ventilator for about 4 days. Now, everything, and I mean everything, is pointing to him getting better. He's stable, he's alert, he even aces a standard breathing test. So the team makes the call, it's time to take out the breathing tube. But then, things take a turn. Less than a day later, just 18 hours, he's in serious trouble. He's struggling for every breath, and they have to put him back on the ventilator. So his doctors are left scratching their heads, right? There's no new infection, nothing obvious. What on earth did they miss? Now, you might think this is just a one-off, a rare case. But it's not. This kind of sudden, unexpected failure, it happens way more than you'd imagine. And that really brings us to the true scale of this whole problem. Get this. The surprising truth is that somewhere between a quarter and, well, almost 40% of critically ill patients fail that first attempt to come off the ventilator. Let that sink in. This isn't some rare thing. It's a huge obstacle standing in the way of recovery for a lot of people. Okay, so what is going on here? What's the hidden culprit causing all these problems? Well, ironically, the answer often points back to the very machine that's supposed to be saving their life. It's a condition called ventilator-induced diaphragm dysfunction. That's a mouthful, I know. But the easiest way to wrap your head around it is to think of the ventilator as a cast. You know, like a cast on a broken arm. The diaphragm is your main breathing muscle, and when the machine is doing all the work for it, well, it's the classic use it or lose it situation. The muscle just gets weak. And this isn't a slow process. It's actually shockingly fast. Studies have shown that the diaphragm muscle can shrink by an average of 6% for every single day a patient is on full ventilator support. Just a few days of the machine taking over can lead to some serious weakness. So this all leads to a really crucial question for the doctors right there at the patient's bedside. Is there some way to peek under the hood, so to speak, a way to actually see and measure how strong that breathing muscle is before they make the call to pull the tube? Well, the answer is yes, there is. And the solution isn't some futuristic, high-tech device. It actually uses a piece of equipment that most intensive care units already have sitting right there. It's diaphragm ultrasound, and it's a total game changer. I mean, think about it. Some other methods are invasive, or you have to move a really sick patient, which is risky. But this, you can do it right there at the bedside. It's safe, no ionizing radiation like you'd get from a CT scan, it's non-invasive, and it's relatively easy to learn. It gives doctors this incredible real-time window into exactly what that breathing muscle is doing. Okay, so when a doctor does this ultrasound, what are they actually looking for? It really boils down to two key measurements that tell them if the diaphragm is, fit for duty. And what's so cool about this is just how simple the technique is. You can see here, a doctor just places a normal ultrasound probe on the patient's side, right on the lower rib cage. And boom, you get this really clear image. That muscle you see there, sandwiched between the ribs, that's the diaphragm. All right, so the first thing they measure is diaphragm thickness. It's honestly just like flexing your bicep. When you take a breath in, the diaphragm contracts to pull air into the lungs, and just like a bicep, it gets thicker. Then, when you breathe out, it relaxes and gets thinner again. And this image just illustrates that perfectly. On the left, you can see the muscle is pretty thin at the end of an exhale. But look at the right. After the patient takes a breath in, it's gotten way thicker. That change, that percentage of thickening, is what they call the diaphragm thickening fraction, or DTF for short. And that number is a fantastic indicator of how strong that muscle really is. The second key measurement is something called diaphragm excursion. Basically, this just tracks how far down the muscle moves when someone takes a breath. It's pretty intuitive, right? A strong, healthy muscle is going to move a lot, while a really weak one will barely budge. So we've got these two measurements. How does this actually help doctors make decisions? Well, when you put them together, they turn out to be incredibly powerful predictors. And this is where it gets really practical. Studies have actually figured out some clear cutoff points for success. If a patient's diaphragm thickening fraction is more than 30%, or if their diaphragm excursion is more than 10 millimeters, it's a really strong sign that they're going to succeed at breathing on their own. This isn't guesswork anymore.
It gives doctors real, objective data to help them make what is honestly one of the most high-stakes decisions in the ICU.
But this is bigger than just a simple pass or fail test. This tool really opens the door to a whole new way of thinking, a much more personalized, much more proactive approach to recovery. I mean, the potential here is so exciting. Instead of just predicting failure, what if you could use this data to prevent it? Just imagine a ventilator that's smart enough to use this real-time feedback from the ultrasound. It could adjust its own settings to give the diaphragm the perfect little workout, just enough to keep it strong, but not so much that it gets tired out. We're talking about a future of truly personalized respiratory therapy. Now, of course, we have to be realistic here. There are some limitations. You need proper training to get good, reliable measurements. And if a patient is on really high ventilator support, that can throw off the readings. And probably the biggest thing is that most of the studies so far are observational. We still need more research to prove that using this tool actually, definitively improves patient outcomes. And that leaves us with a pretty incredible final thought, doesn't it? Could our machines one day learn to watch our muscles and actually help us heal faster? We might be on the verge of a whole new era in critical care. An era where our life support machines aren't just passive systems keeping us alive, but active, smart partners that help our bodies find their own way back to strength.